Hello everyone, myself Dr. Manikanta. Welcome to my YouTube channel. Today I am going to discuss regarding the type 4 RTA as well as approach to hyperkalemia. Okay, let's begin the session. Before discussing a type 4 RTA, you should know regarding the RAS system. That is renin, angiotensin, aldosterone system, RAS system. Okay, so concept of RAS system is the patient will have angiotensinogen. Where angiotensinogen, from where angiotensinogen actually produced, it is produced from the liver, right? This angiotensinogen is converted to angiotensin 1. We know that angiotensin 1 is converted to angiotensin 2, right? By me angiotensin 2, this is angiotensin 2 is responsible for the physiological as well as pharmacological actions, no? It is responsible for the physiological and pharmacological actions, physiological as well as pharmacological actions, right? Angiotensinogen is converted to angiotensin 1 by means of which enzyme? Renin. It is by means of an enzyme which is called as renin. Renin is usually produced from where? JG cell, juxtaglomerular cell, that is located in the JG apparatus. Conversion of angiotensin 1 to angiotensin 2 is by means of an enzyme which is called as ACE. That is angiotensin converting enzyme, that is located where? In the pulmonary circulation. Correct. So what are the physiological and pharmacological action of this angiotensin? It acts on the adrenal cortex. Once it acts on the adrenal cortex, it stimulates the release of aldosterone, right? This aldosterone now acts on where? It acts on the collecting duct, right? If you consider this is a cell of the collecting duct, right? It acts on the basolateral side, and since it's lipid permeable, right? Steroid hormone, it is a lipid permeable, therefore it acts on nuclear receptor located inside the collecting duct cell. It acts on the aldosterone receptor, that is nuclear receptor located inside the cell. Once it binds to the aldosterone receptor, it stimulates the ENaC channels. These are the ENaC channel, epithelial sodium channel, located on the luminal side, that is apical side, causes a reabsorption of sodium into the collecting duct cell. So along with the sodium, what also moves is water, because sodium is osmotic active compound. If sodium moves inside the cell, along with what also moves is water. Now since the sodium is moving inside the cell becomes progressively positive charge. To maintain the electrical balance, it loses other positive charge which are present inside the cell, that is potassium and H plus ions. Correct. Because of this loss of potassium as well as H plus ions occurs. Potassium loss is via which channel? ROMK, and H plus ion is via hydrogen ATPase channel. Correct. Okay. Now in type 4 RTA, why the patient is having hyperkalemia? Because there is no, first of all, aldosterone. If there is no aldosterone, what will happen? Can it act on aldosterone receptor? No. Can ENaC channels are stimulated? No. There will be no sodium and water reabsorption, and there will be no excretion of potassium and H plus ion. That's why the type 4 RTA will have hyperkalemia and metabolic acidosis. Okay, hyperkalemia and metabolic acidosis. Correct. Okay, this is the one reason. So type 4 RTA causes could be aldosterone deficiency, could be due to aldosterone deficiency, or it could be due to pseudo hypoaldosteronism. That means aldosterone is there, but it is not acting on the aldosterone receptor, or defect in the ENaC channel, that is called as pseudo hypoaldosteronism. Okay, in the pseudo hypoaldosteronism, the patient will have manifestations of hypoaldosteronism, but plasma levels of aldo is elevated, as plasma levels of renin is elevated. Correct. Aldosterone deficiency means the patient will have reduced aldo. That's why it is not acting on the aldosterone receptor. If aldosterone receptor is not stimulated, ENaC channel is also not stimulated. There is no reabsorption of the sodium and water. There will be no excretion of potassium and H plus ion. That's why it's called hyperkalemia metabolic acidosis. So low aldo could be due to low renin, or it could also be due to high renin as well. So if a patient have low renin, that means defect where? We know that renin is required for the formation of angiotensin 2, which is required for the formation of aldosterone. If there is no renin, there is no angiotensin 2, there will be no aldo. This is called as low renin, low aldo. That is aldosterone deficiency only with low renin. That means defect in the JG cell. Correct? So what are the causes of this low renin, low aldo? One of the most common cause of type 4 RTA as well as low renin, low aldo is diabetes mellitus. Why? Because in diabetes mellitus patient, conversion of pro-renin to renin is impaired. Pro-renin to renin is impaired. Since the conversion of pro-renin to renin is impaired, there is no renin. There will be no angiotensin 2. There will be no aldo. That's why we get low renin and low aldo. Right? Other reasons is that if you talk regarding this is the JG cell, it contains one receptor which is called as beta 1 receptor. Whenever there is a stimulation of this beta 1 receptor, it causes release of renin. This is JG cell. It causes release of renin, right? Suppose if the beta 1 receptor is blocked, what will happen to renin release? It will be reduced. This will lead to low aldo. That is beta 1 receptor blockers. And in diabetes mellitus patient will also have autonomic dysfunction. Other reasons for type 4 RTA is autonomic dysfunction, which will lead to impaired beta 1 receptor activity, which can also lead to low renin and increased aldo. Next, for the formation of renin, actually what is also required is prostaglandins is also required. That's why NSAIDs will also lead to type 4 RTA, including the CNIs, calcium inhibitor, that is cyclosporine and tacrolimus as well. Next, if a patient is having low aldo but increased renin, that means what? Renin secretion is normal, that is JG cell is normal, and the formation of angiotensin is also normal, but from adrenal cortex there is no release of aldosterone. That means that why aldo is low. That's why the aldo is low, right? Or if a patient is using angiotensin converting enzyme blockers, that means the renin secretion is there, but if a patient is using angiotensin converting enzyme inhibitors, angiotensin 1 cannot be converted to angiotensin 2. If there is no formation of angiotensin 2, adrenal cortex is not stimulated and there will be no release of aldosterone. Or if a patient is using angiotensin receptor 2 blocker, that is ARBs. Example for ARBs. So elevated low aldo, elevated renin could be due to primary adrenal insufficiency. What is the most common cause of primary adrenal insufficiency in India? TB adrenalitis. Overall, autoimmune adrenalitis worldwide. In India, TB adrenalitis. What are the various causes of primary adrenal insufficiency, such as congenital adrenal hyperplasia, Smith-Lemon-Lopez syndrome, AAA syndrome, Algor syndrome, Image syndrome, Millard syndrome, etc. All this not needed. Just remember, TB is most common in India. Worldwide, autoimmune adrenalitis. It could also be due to angiotensin converting enzyme inhibitors, or it could also be due to ARBs. Other drug which can lead to a low aldo and elevated renin is low molecular weight heparin and unfractionated heparin, because they also impairs the formation of aldosterone in the adrenal cortex only. Okay, these are the causes. Suppose if you are having hyperkalemia and type 4 RTA, that is metabolic acidosis, and aldo is elevated, renin is elevated. That means what? Adrenal cortex is normal, renin secretion is also normal. The defect lies where? In the aldosterone receptor or in the ENaC channels. That means aldosterone receptor is blocked. Using which drugs? Aldosterone receptor blockers such as spironolactone. So right here, pseudo-hypoaldosteronism. That means the patient is having a manifestation of hypoaldosteronism but will have elevated renin and will have elevated aldo. It could be due to aldosterone receptor blockers, that is spironolactone, eplerenone. It could also be due to ENaC blockers, because aldosterone acts on the aldosterone receptor and stimulates the ENaC. Once the ENaC is stimulated, there is entry of sodium, then only there is excretion of potassium. If ENaC is blocked, there is no entry of sodium, there is no excretion of potassium. That is example for ENaC blocker, triamcinolone and amiloride, okay, including the pentamidine as well. Next, it could also be due to defect in the aldosterone receptor, that is loss of mutation in aldosterone receptor, either aldosterone receptor or ENaC channels. Loss of mutation. Even though there is aldo cannot act on the aldosterone receptor because there is a dysfunctional receptor aldosterone. This is known as pseudo-hypoaldosteronism type 1A. If there is a defect in the ENaC channel, we call it pseudo-hypoaldosteronism type 1B. Okay. Next, we also have pseudo-hypoaldosteronism type 2. What is the other name for the pseudo-hypoaldosteronism type 2? Is also called as Gordon syndrome. Okay. It is actually due to the gain of mutation where? It is due to gain of mutation in DCT. Gain of mutation in sodium chloride channel located in the DCT. Loss of mutation sodium chloride channel in DCT produces what? Gittelman syndrome. Okay, Gittelman, but gain of mutation in sodium chloride channel in the DCT produces Gordon syndrome. Loss of mutation in case of ENaC channels produces pseudo hypoaldosteronism type 1B, which is autosomal recessive. This is autosomal dominant. Even Gordon is also autosomal dominant. Gain of mutation in case of ENaC produces Liddle syndrome. Liddle syndrome. Okay, these are different channelopathies. I will be taking a different separate class on the channelopathies. I will explain there regarding the Liddle syndrome as well. Okay, pseudo hypoaldosteronism, that is Gordon syndrome. If there is a gain of mutation, that is sodium chloride, that will be increased. That means there will be increased sodium and chloride reabsorption from the DCT. Increased sodium chloride reabsorption will lead to hypertension. Now this hypertension inhibits the RAS activity, renin-angiotensin aldosterone system. This will lead to low aldo. If there is low aldo, what will happen to the potassium and H-base excretion is impaired. There will be reduced potassium and H-base excretion. That's why the patient will have hyperkalemia metabolic acidosis. It's called as type 4 RTA. Okay. The other reason is loss of mutations. I am done. Pseudo hypoaldosteronism type 2 is Gordon syndrome. Other is CTIDs, affecting the distal tubules. Affecting the distal tubules. CTI affecting the distal tubules. Where do you get? Classically seen in SLE, sickle cell nephropathy, SLE, and obstructive uropathies, as well as obstructive uropathies. Okay. That means which part of the nephron is actually affected is? Which part of the nephron is actually CTI? This is glomerulus. This is PCT, loop of Henle. This is DCT. Here we have the collecting duct. Here we have the ENaC channel and excretion of potassium and H+. Suppose if the patient has obstructive uropathies, this is the kidney, right? This is the ureter. This is the bladder, right? Bladder. If there is obstructive uropathy, there is a reflux of urine into the kidney, predominantly affecting the distal tubules first. That's why the excretion of potassium and H+ is impaired, right? This will lead to obstructive uropathy. This will lead to impaired excretion of potassium and H+, and this will lead to type 4 RTA. Okay, type 4 RTA. That's it regarding the different causes of type 4 RTA, out of which the most common cause of type 4 RTA is diabetes mellitus, which is the most common cause. Okay, that's it. Right. Now, what are the clinical features of type 4 RTA? Of course, the patient will have hyperkalemia, and the patient will have metabolic acidosis, Because of metabolic acidosis, the patient will have Kussmaul's breathing, that is rapid shallow breathing. Patient usually perceives as SOP, rapid shallow breathing, Kussmaul's breathing. Of course, the patient can also have nausea, vomitings as well. Correct? Okay. Because of hyperkalemia, it is dangerous. It can lead to affect the cardiac muscles, skeletal muscles, and also affects the skeletal muscles. What is the skeletal muscles manifestation of hyperkalemia? It can lead to muscle cramps. It can also lead to acute areflexic paraplegia. Different electrolytes actually causes acute areflexic paraplegia. One is hypokalemia, other is hyperkalemia, hypophosphatemia, hypermagnesemia. These are the electrolyte imbalance which can lead to acute areflexic paraplegia. Okay, if you want, you write acute areflexic paraplegia, differential diagnosis, electrolyte imbalance. One is hypokalemia, other is hyperkalemia, other is hypermagnesemia, and hypophosphatemia. Okay, this will lead to acute areflexic paraplegia. Cardiac muscle, this will lead to ECG changes. What are the ECG changes with respect to potassium? If the serum potassium is between 5.5 to 6.5, the ECG changes will be seen as tall tent T waves. It will be seen as tall tent T waves. Okay. If it is between 6.5 to 8, the patient will have wide QRS, prolonged PR interval, that is heart blocks, prolonged PR interval. That's why any patients having prolonged PR interval definitely wrote hyperkalemia as well. Prolonged PR interval, absent P wave. If it is greater than 8, the patient will have sine wave pattern, that is impending diastolic arrest, sine wave pattern. Okay, these are the ECG manifestation. Of course, other ECG manifestation, hyperkalemia can produce any ECG manifestation. These are the common things: tall tentative waves, wide QRS, absent P wave, prolonged QR interval, and sine wave pattern. Right. But other ECG changes which can be seen are right bundle branch block, left bundle branch block, extreme axis deviation, Brugada-like manifestation, Brugada-like syndrome, including ST depression and QT shortening as well. Okay, initial stages will have QT shortening, later stages have QT prolongation. That's it regarding hyperkalemia and metabolic acidosis. So here the patient is having hyperkalemia, right? We are suspected, you have sent the electrolytes and it came a hyperkalemia. So how do you approach a patient with hyperkalemia? That is serum potassium is more than 5.5 is hyperkalemia. First step in hyperkalemia is always look for RFT, renal function test, that is a creatinine. If the creatinine is elevated, that is suggestive of either CKD or AKI. Hyperkalemia. Overall, this is the most common cause of hyperkalemia. Most common cause of type 4 RTA is diabetes. Most common cause of hyperkalemia is CKD and AKI. That's why you have to check first serum creatinine. If the serum creatinine is normal, proceed to urinary potassium. Or we can go for TTKG, transtubular potassium gradient. If the urinary potassium is less than that of 40 milliequivalents in 24 hours, that is suggestive of what? Potassium excretion of the kidneys is impaired. That is impaired, suggestive of impaired renal excretion of potassium. Impaired renal excretion of potassium. Impaired renal excretion of potassium. Na? That is suggestive of type 4 RTA. This is suggestive of type 4 RTA. We have various causes of type 4 RTA. I'll explain: aldosterone deficiency or pseudohypoaldosteronism. How to differentiate? We go for serum aldo value or renin value, and we can also go for repeat TTKG with fludrocortisone. In aldosterone deficiency, there will be reduced aldo. In pseudohypoaldosteronism, there will be increased aldo. Pseudohypoaldosteronism will also have increased renin, whereas aldosterone deficiency can have increased renin or low renin. But if you give fludrocortisone, that is mineralocorticoid, if you are giving mineralocorticoid and the TTKG is normalized, that is more than that of 8, that means what? It is aldosterone deficiency, suggestive of aldosterone deficiency. That's why it is acting on the aldosterone receptor, causing the ENaC channel, causing the what? Excretion of the potassium. That's why TTKG is normalized. That's why suggestive of aldosterone deficiency. If the TTKG is still low, that means if you are giving fludrocortisone, that is mineralocorticoid, and still the TTKG is not normalized, that means still by giving mineralocorticoid also there is no potassium excretion, either defect in the aldosterone receptor or ENaC channel. That is pseudohypoaldosteronism. Okay. Suppose urinary potassium was more than 40 milliequivalents. This is suggestive of what? That means renal excretion of the potassium is normal. It is not RTA. Right? This is either, it could be transcellular shift or pseudohyperkalemia. Pseudohyperkalemia. That's it. Okay. Transcellular shift or pseudohyperkalemia. If the urinary potassium is more than 40. Suppose if a patient has hyperkalemia and you did RFT came as normal, and you now do urinary potassium to the patient. If the urinary potassium is less than 40, that is suggestive of RTA, type 4 RTA, that is impaired renal excretion of the potassium. If it is more than 40, suggestive of renal excretion of the potassium is normal, therefore it is not RTA. It could be either transcellular shift or pseudohyperkalemia. Pseudohyperkalemia is improper technique. That is, while taking the sample, if you squeeze excessively the veins, what will happen? There is a lysis of the cell, which can lead to elevated potassium in the blood sample. Okay, that's a pseudohyperkalemia. Transcellular shift. What is transcellular shift? Transcellular shift, we know that this is cell, we have potassium in here, right? Potassium is more inside the cell, outside the cell. This is ECF, this is outside the cell. This is ICF, that is inside the cell. Potassium is more inside the cell. Transcellular shift means there is a shift of potassium from inside to outside. Why there is a shift of potassium from inside to outside? Lysis of the cell. If there is lysis of the cell, what will happen? All the intracellular content is leaked into ECF. So lysis of cell could be due to lysis of cell, that is tumor lysis syndrome, rhabdomyolysis, that is lysis of the muscle cell, rhabdomyolysis. Or if there is increased H plus ion inside the cell. Where do you get increased H plus ion inside the cell? Metabolic acidosis. This pushes the potassium outside, metabolic acidosis. Or it could be due to due to hyperosmotic conditions. Suppose in the ECF, osmolarity is very high. Hyperosmotic conditions such as diabetic ketoacidosis, hyperosmotic conditions, what will happen? There is a movement of water from ICF to ECF. Along with the water, what moves is potassium as well. This will also lead to hyperkalemia. That's it. Okay. How do you treat hyperkalemia? Treatment of hyperkalemia. Right. We have to differentiate whether it is acute state or it is a chronic hyperkalemia. Acute hyperkalemia or chronic hyperkalemia. Acute hyperkalemia and chronic hyperkalemia. Okay. In acute hyperkalemia, we always look for EC changes. With EC changes, without EC changes. With ECG changes and without ECG changes. If a patient is having without EC changes, what you do? And with EC change. With EC change, I already told, that is talt and T wave, sine wave pattern, absent P wave, white QRS, etc. If there is EC changes, always first give IV calcium gluconate by to stabilize the cardiac membrane. Does not reduce the potassium, it is only to stabilize the cardiac membrane. To stabilize the cardiac membrane. Okay, to stabilize the cardiac membrane. IV calcium, how much we have to give? We have to give 10%, 10 ml over 2 to 3 minutes. Over 2 to 3 minutes. Along with that, we have to give other drugs which reduces the potassium. That is IV insulin. IV insulin. Why IV insulin? The IV insulin activates the sodium potassium ATPase channel. This sodium potassium ATPase channel pumps the sodium, 3 sodium out of the cell, and it brings the 2 potassium inside the cell. So by this it lowers the serum potassium. It is bringing the potassium inside the cell. From ECF. That's why it lowers the serum potassium. So how much insulin we have to give? 10 international units in 50 ml, 50% dextrose we have to give. Along with that, we have to give salbutamol nebulization should be given. Salbutamol nebulization should be given. Salbutamol nebulization should be given. Right. One Respilo, how much we have to give? We have to give 10 to 20 mg should be given. 10 to 20 mg of salbutamol in 4 mLNS. Over 10 minutes we have to give. 4 mLNS over 10 minutes. Okay, over 10 minutes. We know that 1 respil of salbutamol contains 2.5 ml, which is equal to 2.5 mg of salbutamol. We have to give 10 mg. Means how many respils we have to give? 4 respils. We have to take the 4 respil, mix it with 4 ml of NS and give it over 10 minutes. That's how we have to give the salbutamol nebulization. Not 1 respil, not 2 respil. It is 4 respils. 4 to 8 respils should be given. Okay, na? Along with IV insulin, how to give 10 units in 50 ml, 50% extra should be given. Okay, how to give calcium gluconate? 10%, 10 ml over 2 to 3 minutes. Suppose if it is without EC changes, what you have to do? No need of any calcium gluconate, just to give IV insulin and salbutamol nebulization. If it is chronic hyperkalemia, what we give? Potassium binders, K binders we give. These K binders enhances the GI excretion of potassium. Example for potassium binders, we have K binder, that is a calcium polystyrene sulfonate powder. We have calcium and sodium polystyrene sulfonate powder. We have patiromer, and we have sodium zirconium silicate, cyclosilicate. That's it regarding the hyperkalemia treatment. That's it. Thank you. Please do like the video, subscribe, and do share with the other people as well. Please. Thank you.